So they have put on the board here some of the information as far as assessment, objective, and no, you're fine. So as far as subjective and objective data, y'all covered a lot, which is great, okay? So they have said that when you're going in and talking to a patient, so where are these patients? Where are you going to find these patients? Okay, so they're going to present to an urgent care, so primary care physician. Usually these are pretty self-limiting. You know, you're not going to really have a whole lot of issues here. But when the patient comes in, they're going to feel horrible because every one of us has probably had a sinus infection. If any of you are maybe suffering from one right now. So some of the things we're going to ask is, you know, when did this start? What kind of pain are you having? Is it pressure? So remember when I talked about, you know, in the health assessment, the questions that you're going to ask them. And in your book, there's health history, health assessment questions in some charts in some of the different chapters. So some of the big things here are going to be congestion, sore throat, thickened secretions. So what does thickened secretions kind of clue you into? Infection. Okay. So can this be, it can be viral or it can be bacterial. So we need to determine which is which. Okay. So what data is going to tell us that it's possibly, quite possibly, viral versus bacterial? So, okay, so viral, will they have a fever? They could. They could have a fever, and it may just be a low-grade fever, okay? So what are some other things that may point us to bacterial? So bacterial, we've got, and she's listed it here, she's got a B out there.
Smell or color of the
okay, so we've got temperature. We've got purulent drainage. We've got, so we could see most of these other things. So fever, so we're going to get temperature and vital signs. So what are their vital signs going to do if it's bacterial? What may you likely see with their vital signs? Okay, so you may see an increased respiratory rate and an increased temperature. Okay, so what do we say, what do we call a temperature? What number? 101. Usually 101, 100.3 to 101, just depends on who you're asking. Okay, so 100, we'll say 100.3, okay? So anything above that, we're kind of pointing in the direction that it's going to be bacterial, okay? Also, their pulse rates increase. So increased pulse. All right. So some of the other things, you know, those are kind of indicators that maybe we need to be looking toward bacterial and doing some further testing. Okay. So what could the drainage look like? The patient can tell you. What descriptions are you looking for?
color.
So color, so what color would it
Yellow,
be? So
green.
yellow or green secretions. So yellow, green. It could even be like a light mucousy look. Could be blood tinged. You know, they may, from the irritation in the cavities, in the sinus cavities, okay? So if we're seeing, we may just see some inflammation in there due to allergies. So that would be just your rhinitis, okay? So just from like an allergen or something like that, they just could have some inflammation in there, all right? So we see edema of the nose, the cheeks, the eyelids. So remember I talked about the maxillary and the frontal sinuses. So you want to do some light palpation on those maxillary and frontal sinuses. If they say that they're really tender in that area, and that's an indication that there's some inflammation and some edema going on, and then we've got to investigate further. They may be blowing their nose, they may be coughing up some sputum, you know, that, and the sputum may be coming from that postnasal drip, okay? So they may have, it may not really be sputum, but they may think that it's sputum, okay? So they said auscultate. So we're gonna auscultate the lung sounds. So what kind of, do you think we're gonna hear anything with it being sinusitis and rhinitis? But it's a good idea to auscultate the lung sounds to make sure that it hasn't progressed on down into the lungs. So what should we hear if it's just something that's in that upper respiratory area? Okay, so we should hear clear or normal lung sounds. All right, so they've listed here the labs. So we're gonna look at diagnostic studies. So a culture and sensitivity, so you may wanna get a throat culture because it could be pharyngitis, which we're gonna talk about in just a minute. Okay, so you can get a culture and sensitivity, a flu test, or a strep test. Okay, so how do we do that? What do we need to teach the patient about those tests?
They suck, both of them.
Okay.
Either
Yes.
swab in the throat or swab in the nose.
Yeah.
Okay, so we're gonna swab the throat or the nose, and it's gonna feel like you're running that thing all the way to the brain.
Yep.
Okay, it is not fun, that flu swab. I just got flu swabbed back a few months ago, and I was like, okay, y'all are killing me. You're fixing to get some brain matter out of there. So, you know, you've got to get up in that nasal cavity to get that specimen. Okay, yes.
My son had one guy about 2 weeks ago, and they didn't do that. They had him like blow out kind of snot and just did it from right there.
Really?
Yeah, they didn't go.
I've never heard of that before. Typically, they always, I guess, maybe.
He's had it done like that before last year, but this
Uh-huh.
year that's what they did.
Huh.
It came back negative.
Well, I've
Did
never.
he get up in there?
I know. Did he still have signs and symptoms?
He got better.
Okay, well, then maybe he didn't have it, but I've never seen anybody do it like that before. Strep test, you know, just to make sure that there's nothing going on in that oral pharyngeal area. So they may want to just to rule out that there's nothing else going on and that it is just a viral or bacterial sinus infection. Now, you got to kind of be real careful with these sinus and rhinitis, especially if they're bacterial, because if they're not treated, those things can migrate. You know, they can migrate to the brain. You know, it's a real vascular area there, so blood flow, it can migrate. Another thing, we didn't talk about it, but this can happen from, you know, ear problems. So it may start with an ear infection and everything kind of gets clogged up in there and it migrates because everything is attached. So you also want to look at those ears or have the advanced practitioner look at that ear, look at that tympanic membrane, because that may be an indicator too. You know, sometimes we see a bulging tympanic membrane if there's some kind of sinus something going on, okay? So if it's chronic, they can do an endoscopy or a CAT scan. So chronic sinusitis, you know, you may see somebody that just constantly has chronic sinus problems. I have a cousin that he has chronic sinus problems, but he did it by his own account because when he was a little boy, he shoved a raisin up his nose. And so ever since, he has had problems with his sinuses. So, you know, it got stuck and we had to take him, or his mom had to take him to the emergency room, and yeah, it was a big ordeal. So he suffers from chronic sinus problems. So if it's something that's chronic and, you know, it's more than 3 to 4 weeks and the patient just keeps coming back in and they keep presenting with the same symptoms, they may want to do some kind of endoscopy just to make sure that there's nothing going on in those areas, or a CAT scan to see if there's consolidation in there, to see if there's an abscess, because you can get an abscess up in there and then that can, you know, really be bad. So they may want to do that. Interventions. So if it's bacterial, we're going to give antibiotics. So I come to the clinic and I've got viral sinusitis, and I am just demanding that I want an antibiotic. So you're the nurse, Tiffany, what are you gonna tell me?
That antibiotics do not work on viruses. So
Okay, so antibiotics do not work on viruses. So that's an important patient teaching for anything, for anything, because some of these respiratory disorders can be viral. You can have viral pharyngitis, it's not caused from any kind of bacteria. It's going to be self-limiting. You're just going to treat it with things that are going to make you feel better, those hydration and rest and those kinds of things. But, patients are going to demand an antibiotic. And we, as the nurse, have the responsibility to teach them that we don't give antibiotics for viral infections, because what can happen from that? We get resistance, we get drug resistant organisms and those kinds of things. I can't tell you how many people. Okay, so saline nose sprays, warm compresses, those saline nose sprays just help to loosen everything up and mobilize those secretions, all right? Drink plenty of fluids because you want to mobilize those secretions. Decongestants are a great thing. And then if they're having pain, those sinus areas that causes lots and lots of pressure, so they can, if they're not contraindicated, use these. If patients have high blood pressure, then they need to really think about using any antihistamines and talk to their primary care physician before they take any over-the-counter antihistamines. Coursing HPV, patients who have high blood pressure sometimes can take Coursing HPV just so that will help to relieve some of the symptoms. But they have to really, really be cautious. Okay, so use caution with hypertension when we talk about antihistamines. Okay. And then if Tylenol or ibuprofen are contraindicated, that would be something. If somebody's taking another pain medication, that's got Tylenol in it, you don't want to tell them to take Tylenol if they routinely take like a Lortab or something like that, hydrocodone that's got acetaminophen in it. So you've got evaluation, so you want them to return to the clinic because they're not going to be in the hospital for you to evaluate these interventions. So your teaching is going to be to teach them to look at these things, and if they're not feeling better in a few days, to come back to the clinic or come back in 7 to 10 days to be evaluated. Finish their medications. So if it's bacterial, we're going to have an antibiotic. And not finishing an antibiotic can be just as bad as giving an antibiotic when it's not warranted. So, you've got patients who want the antibiotic, and then you've got some that you give it to and they don't finish it. So that can be just as important. So an evaluation, you can tell them if they don't have any drainage, if that drainage is starting to clear up, if their pain and tenderness is decreasing. Most people are going to know this, but it's just good to reinforce those things. Good. I'm glad to see y'all say homeostasis achieved. Teach. Give them written and oral. I like that you wrote that up there. You want to make sure that the patient gets written and oral information. Okay. Complete their meds. Drink plenty of fluids. Things that feel good, if it's getting down into the throat, things that feel good to the throat. Yogurt's good if they do take an antibiotic. And then call the doctor if if they're not getting any better. Okay? So you want to call and report. So any questions? That's kind of all of it grouped together. So any questions about those disease processes? Anything? All right. So let's move on. What's our next one? Asthma is, what's the next one on the PowerPoints? And we'll try to keep it with the PowerPoint. Okay, so pharyngitis. So I'm going to move this to the back of the room. I've got to have a black marker. Okay. So let's talk about pharyngitis. This blood marker will be okay. So let's talk about pharyngitis. So what is pharyngitis? We just talked about sinusitis. So pharyngitis is going to be in the throat area. So the assessment, we're going to look at their vital signs. So what do we expect with the vital signs?
They're gonna be up.
Okay, so we're probably going to have an elevated what?
Temperature.
Elevated temp, possibly. There again, remember over there, 100.3 or greater. So they may complain of difficulty in breathing because probably everything is going to be, stopped up, especially if they've got pharyngitis. There may be some inflammation in there, and there may be inflammation in that nasal cavity and nasal sinus area. So they may have dyspnea or increased respiratory rate. Okay. The assessment of the oral cavity is really important. So what's the throat probably going to look like?
Red.
So red, swollen, and there's a real good picture in your book of pharyngitis. It's nasty looking. So what else in the throat? What else are we going to be looking for?
Like hydration.
What?
Hydration of the oral.
Okay, so hydration. So is it dry or is it moist? What else? What else am I going to look for?
Smell.
Smell. Okay, and that kind of goes along with tonsillitis. We should have probably had these two together. So smell. But what about exudate?
Yeah.
Okay, there might be like white patches on the back of the throat. There could be, some kind of exudate there. So, okay, so exudate. So the oral mucosa, what is it going to look like? So like the buccal mucosa, the gums, the hard and soft palate, those could be reddened too. They could have some thrush going on. You want to just really look at that oral mucosa, all right, and see exactly what it looks like. Is it beefy red? But the throat is the telltale sign. So we're going to look for signs of dehydration. So those oral mucosa that is not real well hydrated, because the patient may be hurting, their throat may be hurting so bad that it hurts them to swallow, okay? So we may be exhibiting signs and symptoms of dehydration. So our diagnostics that we're going to go along with our assessments, because when we're looking at diagnostics, we're assessing what those diagnostic tests look like. So what does that look like for the patient? That's going to give us an indication of what interventions that we need to do. So a flu swab and a strep swab and a chest x-ray. Okay, these are real good diagnostics. Another diagnostic is maybe a CBC. Okay, and what's a CBC going to tell us?
It tells if our white blood counts up.
So if our white blood counts up, and more specifically, if there's neutrophils or if there's eosinophils. So if there's neutrophils is high, what do we think might be going on? Okay, and what if the eosinophils are high? So it may be contributed to allergies. So that's what we want to look at. We want to look at that differential in the CBC. We'll look at the white count for sure, but we want to look at that differential too, because that's going to give us some good information there. Okay, if there's anything going on. The strep test is probably one of the biggest that we'll see done when it comes to pharyngitis. Okay, and then that's going to drive our interventions. If it's strep negative, are they going to put them on an antibiotic? Possibly, because sometimes strep won't show up early, and if they have all of the signs and symptoms. So what would warrant putting them on an antibiotic with a negative strep?
CDC results?
CBC and fever, those are two of the things that we have to look at, because those may be indications that this strep is just not showing up. It could be something wrong with the test. It could be, I've seen patients that tested negative for strep and then they went back a day or two later and they tested positive for strep. And strep can be very dangerous, especially if somebody's got, a heart condition. It can quickly go into other problems. So you don't want to mess around with it. So a strep test and a flu swab, because that could be some of the early indications, some of this, that they're getting flu, okay? Because flu presents in many different ways. They may just feel lethargic, all the way up to, having the full-blown sinusitis, rhinitis, pharyngitis, tonsillitis, everything. They may have nausea, vomiting, all of it, okay? I sure don't want it. Thank you, Lord, for a flu shot. So a flu swab is really important. So our interventions, we want to determine if it's viral or bacterial. We're going to treat with antibiotics if it's bacterial, and if it's viral, we're just going to treat the symptoms. So how are we going to treat the symptoms of pharyngitis? So discomfort in the throat, inflammation in the throat. What are we going to do to treat the symptoms?
Give them Tylenol.
Okay, so Tylenol or ibuprofen. Okay, what else?
Chloroseptic spray.
Okay, chloroseptic spray. Okay,
Maybe gargle with warm salt water.
warm salt water. Okay. What else?
They can eat something easy on your throat.
Okay.
Popsicles.
Popsicles, okay. So, cool things, cool to cold. And they could even do like an ice collar. I think your book talks about an ice collar, putting an ice collar on, that just helps. Popsicles. Some people like warm things. It makes their throat feel better. Some people don't tolerate the cold things. They just want room temperature, or they want something warm. So, it just depends on the person. So they may want warm, they may want cool, all right? So if it's bacterial, what do we need to teach them?
Take antibiotics completely.
Take all of their antibiotics, okay? Is that a priority intervention?
Yes.
Okay, so that's always going to be a priority intervention for these patients when we're talking about the nursing process, because we don't want them to come back later on and have a worse infection because they didn't take all of their antibiotics. My mother had strep throat. My mom, we had a really bad car wreck in 1976, and my mom was in the hospital for eons. Like, she was in there for 6 weeks. And her spleen ruptured, so they had to take her spleen out. And the spleen filters, and it helps with filtering of any bacteria that comes in the body. So they took her spleen out, and she got home. She had strep throat 11 times in 1 year. And the doctor finally said, "Are you taking all of your medicine?" And she was like, "No, I get to feeling better and I quit taking it." That was what was wrong with her. She wasn't taking all of her medicine, so she kept having recurrent strep throat. She finally took all of her medicine and she got rid of the strep throat.
Wow.
So, she was so much better. Encourage fluids. And why would we want to avoid dairy in these patients?
Like the secretions are gonna be.
Right, it makes the secretions thicker. If they've got like secretions in their throat, they can be more tenacious. So we want to avoid dairy if possible, okay? So we want to encourage fluid intake. So do we want to encourage things that are going to dehydrate them? We want to do like Gatorade, Sprites, those kinds of things. You don't want to use like caffeinated things because those things tend to dehydrate you. Okay, so want to encourage that. So patient education, prevention, hand washing is wonderful, and avoiding crowds. Taking the full course of antibiotics, encouraging rest. These patients need lots of rest. We usually want people up and moving to make them feel better, but when these folks, it's pretty self-limiting. We want to encourage them, get plenty of rest and alternate that with, being up out of the bed, because if they're not, then they can have some of these other respiratory issues. But definitely encourage them to rest. And this, if you think about it, this can really be a priority intervention or priority teaching, throwing that toothbrush away. Because you should switch your toothbrush every so often anyway. I don't know what I switch my toothbrush all the time. I thought that's what it was sticking in my mind, but I wasn't sure. But, if you think about somebody that has chronic pharyngitis, maybe they're not ever throwing their toothbrush away, and that may be a contributing factor. So, throw your toothbrush away and get you a new one. Your dentist will give you a new one. All right, any questions about pharyngitis? That's it in a nutshell. So good job on that. Just make sure that we're encouraging them. Where are we going to see these folks?
ER, urgent care too.
Same places, ER, urgent care, physicians' offices. All right. Okay, so no questions on that. All right, what is next?
Tonsils.
Tonsils. Okay, so let's move over here to tonsils. Every so often somebody check this recording and make sure. I'm going to make people sick probably when they look at this from moving it, but okay. I'm going to set this right here, I think. Maybe just move down just a little bit. That one's maybe hard to see on the recording, but hopefully as we talk about it. All right, so tonsillitis. Let's talk about tonsillitis and the manifestation. So we see sore throat, fever. Why is snoring a manifestation? Okay, so if those tonsils get swollen in there, it can obstruct the airway and it can cause snoring, it can cause sleep apnea, it can cause these folks to have some issues, okay? So those tonsils, if they get really, really big, and I've seen some tonsils when I've done surgery, taken some out that were ginormous and blocking the airway. Difficulty in swallowing, the adenoids may be blocked or swollen too. So all of these things, the enlarged adenoids can cause mouth breathing, okay? Because those adenoids sit behind that nasal cavity. So if all of that's blocked and the adenoids are swollen, they're not going to get air into that upper airway through the nares in the nasal area, so they're going to mouth breathe. And then when they mouth breathe, that's going to make their mouth dry. It's going to make their breath smell worse. So those two things kind of go hand in hand if the adenoids are swollen. Tonsillitis can lead to ear infections just because everything, like I said already, is so closely in relation there. So you may notice that the patient has more ear infections and more just basic upper respiratory tract infections, okay? So upper respiratory tract infections can lead to tonsillitis, but then the tonsillitis can contribute to those upper respiratory infections, okay? Especially people who have chronic tonsillitis. Head colds, those are all manifestations. Bronchitis, foul-smelling breath, noisy respiratory. So sometimes especially these kids, we see this more frequently in kids. So when they breathe, they kind of sound like they're gargling, just kind of like because those tonsils are blocking the airway. So they just kind of have noisy respirations. And it's just, it can, as a parent, it can really drive you crazy. And they talk real nasally because those adenoids, if they're swollen, you know, they will be blocked off. So on physical examination, what are we going to examine? What are we going to look at? So we're going to look at the throat, the ears, what else? The nose. Because it could be something in the nasal cavity that's causing the obstruction, if we don't know yet that it's tonsillitis, okay? So we're going to look at the throat, the ears, and the nose. And then what else? We're going to look, but then we're going to palpate. So what are we going to palpate? Okay, so the cervical lymph nodes. Okay, next semester you all will learn all of them, but there's cervical lymph nodes all around. This area is very lymph heavy. Okay, so you've got all kinds of lymph nodes down in here. So your tonsillar lymph nodes are right along in here. So you're going to feel and palpate right along in here, okay? So we want to feel and see if that area is swollen, and look in the back of the throat as well and see if what we feel is consistent with what we're seeing. Okay, so that tissue, and they may have swollen lymph nodes all the way. You've got some right behind your ear, some in the occipital area back in here. You've got them all the way down through here, cervical change and subclavicular. Mostly, you're gonna feel right along in here, okay?
So what's it feel like a lump?
It can feel like a lump. It can feel very swollen. I don't have tonsils. I had mine taken out when I was 32 years old. Do not recommend it. Not at all. So, are yours swollen? Okay. So, Jordan has swollen tonsils. So, anybody that wants to feel of her swollen tonsils, I'm going to keep on going. So, we want to look at that. Look at the tonsils and see if there's any exudate on there. So look at the tonsils themselves, and okay, and look for exudate. So tonsillitis and pharyngitis kindly go together, because if you've got tonsillitis, you may have pharyngitis. Okay, not always, but you might. So we want to examine those tonsils and look at them. We want to look and we want to feel. Okay. And then the RADT assessment, y'all can look at that in your book. But on physical exam, we may see that all of these manifestations, you're going to gather all of these things, because the patient, when they come in, you're going to say, what's brought you here? Well, I've got a sore throat, I can't breathe very good, I can't swallow very good. They may describe it feeling like a razor when they swallow. You know, I'm not sleeping very well, I'm having to breathe through my mouth. All of these things under the manifestations, you're going to see when you're asking them their questions or you're doing your physical exam on them, okay? Most all of them. So medical management, increase fluids, give them some analgesics, saltwater gargles, rest. If it's true tonsillitis and there's infection there, then they're probably going to start them on penicillin if they're not allergic to it. If they're allergic to it, then they'll switch it to something else. The best way to manage tonsillitis, chronic tonsillitis, is a tonsillectomy, okay? So let's talk about some of the post-op, and they probably have got everything over here covered. So most of the time we see this, we see tonsillitis in pediatric patients. If it is presenting in the older population and somebody who is, you know, past their teens, when we do surgery, the risk is a lot greater. Okay, it takes them a longer time to heal. I had mine out when I was 32. My nephew was like 9, I guess. 9 or 10, he had his out the day before me. Same doctor, same facility, everything. He left there and ate a cheeseburger. I couldn't eat for 2 weeks. I had water. I lived on water, room temperature coffee, and vanilla pudding. That was what I lived on for 2 weeks because I couldn't swallow anything. I tried to eat a French fry. I could not even chew and swallow a French fry because my jaws hurt so bad, and then I was so swollen. I mean, he was back to school in a few days, and here I am, like I'm laid up for 2 weeks staying with my mom because my husband couldn't take, he was like, I gotta go to work, I can't take off and take care of you. So I stayed with my mom, and I had a baby, Zoe was like 2 or 3, so my mama took care of me. Mamas are good like that. So you don't want to wait until you're older to do it. The biggest post-op complication, pre-op, you've got to educate them on what to expect. To expect pain, that they're going to need pain medication about every 4 to 6 hours. They may need something for nausea at least the first few days, and they're going to have to be on some antibiotics post-operatively. They usually put you on some antibiotics post-operatively. The biggest thing post-op is hemorrhage. So you want to teach pre-operatively the things to look for with hemorrhage. So can you see a hemorrhage in the throat? Because what they do is they go in there and they cauterize those, they grab those tonsils and they cauterize them out. So it becomes like a blackened area back in there where they cauterize that tissue out. So it forms a crust over that area. So once it forms the crust, after a few days, that crust can break off, okay? That's why you advise them not to eat anything rough, like potato chips or popcorn, anything with a husk on it or anything like that, because that can cause that crust to come off and then they can hemorrhage. So how can we determine if they're hemorrhaging, and how can we teach them what to look for, because they're probably going to be at home. They might keep a smaller kid who's at risk in the hospital for just a little while. So what are we going to look for?
When they taste like metal or
Okay, may taste like metal. They may have a metal taste in their mouth. They may actually be spitting up frank red blood. They may, if they're swallowing it, they may be spitting up dark blood because it's mixed with gastric contents, so they may cough that or vomit that up. So if that's the case, that may be an indication. It may just be old blood where they swallowed it during surgery. A little bit of it might have gotten down there in surgery or right after surgery, but usually that airway and everything is protected. They usually put an NG tube down to protect everything. But they may do that. Repeated swallowing, lots and lots of swallowing. If they're swallowing a lot, that may be an indication that there's bleeding going on, okay? They need to kind of examine that throat. Usually about day number 8 is when the most opportune time for bleeding occurs. It can happen anytime, but your priority is to teach these folks how to avoid bleeding, and sometimes it's just not avoidable. I mean, it can just happen. It can be a fluke thing, and it can just happen. But to understand how to manage that. So in the immediate post-op period, and I think Dr. Jones talked to you all about post-op care. So in the immediate post-op period, as the nurse, you want to monitor them for hemorrhage, okay? So monitoring them for hemorrhage means we're watching any kind of vomit or anything that they're spitting up, because you're probably going to give them an emesis basin because everything's kind of numb back in there, so they may just have a lot of saliva. It is normal to have some bleeding. Okay, it's normal to have a little bit, but if you have copious amounts of blood coming out, then there's something wrong and they need to go back in there, and look, there may be a little bleeder or ligation that needs to be done. The best thing to do, I think your book says, position the patient prone with their head to the side. I have never, in all of my years as an OR and a post-op nurse, ever turned a patient prone after a tonsillectomy. I've never, we just always put them in, we first put them in supine position and raise the head of the bed to a semi or high Fowler's position to help all of that drain out. We do keep their head turned to the side so that, it helps to drain those out. But your book, when I read that, I was like, prone position. I've never done that before, but oh well. I guess that's the best position for them. So you don't want to remove this oral airway until their gag reflex has returned. Now that may be a little while, okay? But if the patient's starting to wake up and they're gagging against that oral airway, then you can take that out, okay? But you want to leave that in there because that's going to protect the airway. It's going to protect any of those secretions from going into the airway and into the lungs and causing an aspiration, okay? An ice collar to help reduce the swelling. So you want to put some ice on that throat, make sure that you're getting that in there, and then water with ice chips in it. You don't want them to talk too much, and you especially want to avoid forceful coughing, okay? If they cough forcefully, that can cause those scabs back there in the oral cavity to break loose and cause a hemorrhage, okay? So you do not want them to talk a whole lot or cough a whole lot. So after, in the immediate post-op period, they can leave after they drink and void, but we've got to talk to them about those signs and symptoms of hemorrhage, especially during that immediate post-op phase, and teaching them the foods to eat. So, within the first 2 weeks, they really just need to eat soft foods, nothing that's going to be real rough, nothing that's going to be real hard to swallow, like popcorn, potato chips, those kinds of things that's got a rough edge on them, because those can really mess with that scarring. Liquid Tylenol with codeine, just because that is much easier to swallow than a pill. Okay, so we want to do liquid Tylenol. Usually in about 3 to 5 days, the pain will subside, and they'll notice that they've started taking less and less pain medication. I'll tell y'all, when I had mine done, I literally was turning the bottle up and drinking it. I mean, I had a bottle, I told the doctor, because he usually wrote pills, and I was like, okay, first of all, I can't swallow a big horse pill. Second of all, I just want liquid. Just give me liquid. So he gave me liquid antibiotic and liquid pain medication. I just go in there. I would wake up about every 4 hours, and I would just go in there and get the bottle, and I think, oh, I measured it the first few times, and I thought, oh, I can just, and I was just taking it up and just downing it. I was like, Lord, have mercy. My mom goes, what are you doing? I said, I'm tired of measuring it. I literally didn't have the energy. I was just, going nonstop. So, alkaline mouthwash. So you want to, or just warm saline mouthwash, because you don't want these folks to use like Listerine or Scope or something like that. You want them to just use something that is just kind of an alkaline type. Warm saline is just the best thing to use. And I would not advise them to do a whole lot of aggressive mouth washing, okay? Because that can cause those scabs to come off too. They just want to do some gargles. They're going to have horrific breath. They will not want to be around anybody for a few weeks, because until those scabs comes off, it is horrific. Has anybody had a tonsillectomy? Yeah, a few of you. Okay. So do y'all remember it, or were you small children? Small? I don't even want to think back on it. Soft foods, nothing hot or spicy or acidic. They don't want to eat like spaghetti or hot chili peppers or anything like that. Use a humidifier. That will help, because they're probably still going to do some mouth breathing, so that's going to dry everything out, and those can cause those scabs to be worse. Okay. Don't smoke, and no heavy lifting. Let's see. Oh, yeah, and you want them to avoid vomiting, so they may need some antiemetics. So if they do, you want to teach them, to keep those antiemetics on board about every 4 to 8 hours, however they're ordered, so that they do not vomit, okay? Want to avoid that. Any questions about tonsillitis? Y'all did a really good job. Y'all covered everything up here. I didn't have to write very much on that. They have went ahead and wrote up here epiglottitis. That's in your pediatric book. So I just want to touch on that for just a second. So epiglottitis is inflammation of that epiglottis. It is a pediatric emergency. Okay? So, bless you. Can somebody let her in? It's a pediatric emergency. You have abrupt respiratory distress. So the patient is probably going to report a sore throat and a fever. And as far as what you need to do as the nurse is to send the patient for a chest x-ray. But if this is a medical emergency, you've got to manage an airway. You have got to get an airway on this patient. Because you think about the epiglottis is the little notch that hangs down in the back of your throat. If that swells, that can cover the airway, and the patient can die in just a few minutes. So it is very, very life-threatening. So you want to maintain an airway. Once you get an airway, the patient may have to be intubated. Okay. Yes, if it is to the point that they are not getting any air through. Now they may have like a stridor, something like that, because their airway is blocked, but they're getting a little bit through. So they may have to have some steroids. They may have to have some medications to decrease that swelling in there. But this is an emergency. You got to get them up so that you can maintain their oxygenation, put oxygen on them, and find out what the cause is, okay? But it is a medical emergency. You want to look at that mouth and the throat area, if you can, if it's not contraindicated. But you don't want to do anything that's going to cause any further swelling, okay? It may, there may be things that causes some further swelling. If they're opening that up, it may cause the swelling to be worse. All right. So, these kids are going to be very anxious. So we want to make sure that we reassure them, we're calming with them, and work with them to try to decrease their anxiety. Any questions about that? That's it in a nutshell. I mean, it's like 2 pages in your pediatric book. Okay. All right, which one's next? What's next? Anybody know?
That's all on that one.
Is that all on that one?
That one, then it goes to atelectasis.
Oh, yeah, thank you. Okay, so we're going to atelectasis next. Where is that one? Who did atelectasis? Of course, it's on the other side of the room. Okay, I'm going to stop this and start